Hello, my name is Dr. Martin Chavez, and today I have the privilege of introducing some new technology from our colleagues at Samsung. We're going to start evaluating our myocardial perfusion index. This technology has been around, but one of the challenges that we faced was how to best implement it. And hopefully I'll be sharing with you some of the techniques that we've used in our laboratory to best implement it for our practice and our patients, particularly the at-risk patients. So we're going to review a brief history about fetal heart evaluation, review fetal cardiac circulation, a tale of two hearts, and I'll tell you what that means in a second. We'll also become familiar with MPI, or myocardial performance index, both left and right, and we'll show you why there's a difference. Review the clinical scenarios MPI can be utilized in, assess how MPI has been incorporated into our high-risk maternal fetal medicine practice, and review other potential clinical uses for MPI in the future. A little bit about our team. We're a large MFM practice, 11 maternal fetal medicine specialists. We have 7 nurses, 1 nurse practitioner. That number of perinatal sonographers is constantly changing, so we're up to probably 30 now. We have our own MFM fellowship, and we have a very supportive administration. We do around 30,000 or so ultrasounds a year, and we have 13 sites, and we are literally running 7 days a week, close to 360 days with a few holidays thrown here and there. We also have a lot of services, and these services are meant to provide support and capture patients who need these resources where there's a pregnancy where the fetus has an abnormality, particularly when it's the heart. We also collaborate with our colleagues, Peds Cardiology, that allow us to not only initiate care during the pregnancy, but also provide care throughout the pregnancy and even after the baby's born. And that's very important. There's a new concept taking hold about fetal cardiac health. The reason I want to put that phrase out there is because a lot of things that happen in utero will determine what the health of that individual will be after it's born, whether it's a neonate, early on in childhood, teenage, and even adulthood. We also have to remember that when we do find these things, we have to know what to do with them and how to best manage these patients. We do this with collaboration with our Samsung colleagues where we test their equipment and we're constantly pushing the envelope. The reason we invest in this is because we also know that unless we try to push the envelope, unless we make sure that we're using the best technology out there, we're going to stay stagnant. And that's not why we went into medicine. And that's always an important factor to remember. We also make sure that the technologies are going to meet not only the needs of the high-risk patients, but also the providers that utilize them. You can have the world's best technology, but if that technology is not easily adapted or easily learned, and is a skill set that that individual, whether it's a perinatal sonographer or an MFM doctor, can easily implement on a regular basis, it's not going to be a technology that's going to be utilized on a routine basis, particularly when it's needed. When you look at this, we see that we collect a lot of information all at once. And you can see on the left-hand side how quickly and how often the sonographer is moving all over that console. And if we activate the video on the right-hand side, you'll also see that that movement is on the abdomen as well. One of my close colleagues just the other evening had mentioned about how ultrasound is probably the most intimate mode of imaging that's out there. And I thought about it for a second, and that individual actually made a lot of sense to me and shared insight with me. Because when you look at it, right, that individual is exposed, and that individual has direct contact trying to get that information for that pregnancy. But that's also, that intimacy, that closeness also gives reassurance and bonds that patient with that perinatal sonographer as well as that clinician. So let's start on our journey, right? Because we always want to go back to history to remember what we've learned to build upon. These two gentlemen actually came up with the concept, right? Their hospital in in Sweden was next to a shipyard. And they went next door to the shipyard, and they were using some technology that was actually being used to test ship hulls and ship beams, metal beams and everything else. And they said, well, that's interesting. I wonder what would happen if we took this technology and started implementing it on humans. So they lugged this big machine over, and they started scanning themselves, and they realized that they can actually see the deflection of the cardiac myometrium in real time. And it struck them that, wait a second, we can utilize to see what heart function is actually doing in real time and help that patient get better care and also evaluate that patient as we treat that patient. Now, we're going to jump a little bit further, right, because we have only a certain amount of time and we want to cover a lot today, but I think it's important information. And we have Dr. Tai, who came up with the concept of saying, I have these cardiac failure patients, and I need to evaluate them in a very thorough but easy manner. And he came up with the Tai index. What's that name? After the Tai index, also known as the MPI, myocardial perfusion index. And Dr. Tai realized that he can do this in adults. Now, this was the beginning of being able to evaluate the performance, the ability of that heart to work in whatever environment it's necessarily in. Next slide. Now, of course, we're going to jump a couple decades later. And as you know, a lot of things that we do in the fetal world starts in the adult world. From the adult world, it goes to the pediatric world. From the pediatric world, it usually finds itself to the fetal world. And we know that we can look at imaging, and with this imaging, we can evaluate the structure, we can evaluate flow, but we needed that extra piece to try to get information as to how well that heart was working. Because that heart not only is working for that fetus, but also it's working with that environment, right? So that heart is a barometer for the maternal circulation through the uterus, through the placenta for that fetus. In addition to that, it also gives us information as to how well that fetus is reaching its potential for the best possible growth, the best possible perfusion. We know that we can get exquisite imaging when it comes to fetal echo. We know that we've made leaps and bounds over the last couple of decades when it comes to evaluating the structure, the flow, and we're pretty darn good, not perfect, but pretty darn good at detecting a lot of these major anomalies. We have room to improve by all means, but I think that we've made huge leaps in the last couple of decades. We're going to talk a little bit more about where we feel that MPI or myocardial perfusion index comes in and some of the steps that along the way technology has helped us get there. Because these can be very easy, but also at times complex measurements and also processes to do on a fetus, particularly when it's moving, particularly when the mom has to be repositioned. So there's a lot of factors we need to take into place. We also know that the fetal circulatory system is a very complex and a very exquisitely efficient method for that fetus to get the nutrients, the oxygen, and everything else it's going to require to develop. We also know that we're visual, and we can get a lot of information from the visual information that we get. And if we have the right tools, we can do this much more efficiently. This is an example of LumiFlow, and we'll have other presentations at other times, but LumiFlow is one of those things that really allow us to perceive the fetal circulation in a manner that makes much more sense to our 3D brains or binocular vision. This is another example about how it's important to get that information when we look at the heart in a manner that makes sense to us. So this is a 4-chamber view with color and LumiFlow, and it makes sense. It allows us to visualize and understand that, yes, it's a 2D image, but it's actually 3D dimensional information that we're gathering from that image. Okay, so let's start on a tale of two hearts. In fetal life, we have the right and left circulation. And this is because the fetus is not breathing. It's not utilizing oxygen exchange through its lung. Everything is occurring through the placental interface and the uterine interface. But we also realize that the heart itself adapts as the fetus goes through different phases of stress, or the fetus goes through different aspects of environmental changes in the uterus, whether it's through uterine placental insufficiency, whether it's through a cardiac defect, whether it's through other environmental factors. The fetus is very well adapted to compensating for these changes to a point. And here's where NPI really is going to be important, particularly when it comes to trying to get the correct side of the heart or the right side of the heart to get that information. And I'll share with you some slides as to how in our unit we're able to get that on a pretty regular basis and pretty easily. We know that there's some key factors in fetal circulation, right? Unlike the left side in adults or in newborns, the right side is dominant in which the ventricle accounts for more than 50% of the total cardiac output. That's important because that's what's actually going to change first when there is a stress on that fetus, when there is a concern for that fetus. And if we can use that as a barometer for that fetal health, fetal cardiac health, right? It's going to allow us to modulate our frequency of surveillance or timing or location for that fetus of delivery, whether it's at a basic hospital or a tertiary hospital where we have more complex services. This is a diagram, right, of fetal circulation and a newborn heart. Right? As you all know, when you took your physiology classes and your anatomy classes, there's certain things that happen, right? There's 3 fetal shunts. You have the foramen ovale, you have the ductus venosus, you have the ductus arteriosus, and all of those basically shut down and close for the most part once that baby takes that first breath. Now, there's some interesting anatomical differences, particularly earlier on. If you look at the left side and you see it, an image come up, I'll put up some markers on the screen, you'll actually see that on the left side, right, the mitral and the aortic valve are very close to each other. And they tend to stay relatively close to each other throughout all trimesters. Now that's important because when we looking at NPI on the left side, right, it's easy just to put one gate on there. And that's the concept behind modified NPI, where you only have to put one gate and it captures both inflow and outflow of that side of the heart. If you look at the next markers, you see that that gate can be very, very close to both of those valves. But here's the challenge on getting it on the right side. If I look at the next markers that go up, you see that already you notice that the tricuspid and the pulmonary valves are further apart. And that distance actually increases as the trimesters increase. So while I might be able to get away with it in the second trimester, in the third trimester, that distance is a little bit more challenging to get in one gate, if not impossible. That's why when you look at the modified NPI, getting it just on the left side is easier, irregardless of gestational age because of the distance of the valves, but on the right side, it's a little bit more challenging, particularly in later gestations. If you look at the markers that's going to come up on the screen, you see that if I put that one gate there, I might get close to one valve, the tricuspid, but not the pulmonary. So what I need to do is take out that gate and put in 2 gates where allowing me to measure those. But here's where it gets challenging. You would have to either manually or visually try to calibrate these 2 so this way they will actually make sense. If you've ever seen a movie being made, right, there's always at the very beginning some guy comes out with a big, like they call it a clapper, I guess, and they click it saying sound check. And that sound check is to sync the video with the sound. And that's an important concept to remember, right? Because without that synchronization, you'll have someone talking, but the words are either lagging or ahead of what they're saying, and it's not synced. Keep that concept in mind when we talk about this. If I'm looking at an image and that camera, right, is allowing me to see two things within its field of view, I can get information in real time or synced together, right? I can see that I can keep an eye on both those doors, and I'll know who's coming and going and the time relative to who's going in and out of those doors. So think of those doors like valves in the heart. But if I have two different doors and those doors are being watched by two different cameras, it's more challenging to sync them up, particularly if there's something going on that needs to be evaluated at the same time. Because if you don't evaluate them at the same time, you don't know if it's occurred at the same time. So if I have two cameras and I see one person leaving, another person coming out, I'm not sure if it's happening at the same time or temporally different. If we go to the next one, and through this analogy where you have two cameras, then I go to the next step, and the next step after that, what we're trying to do is sync them together. So what we do is we have one image coming into view, we have another image coming into view, but then through synchronization, we align them time-wise to allow us to interpret what's happening at the same time. So if I go to the next step, then this synchronization occurs at that point. So now I know that when I'm looking at these valves, even if they're apart, or these doors that are apart, I can synchronize the time to know exactly when it's occurring. And that synchronization is important, particularly when we're looking at the right-sided fetal heart function. And that's where MPI Plus comes into play. So before we dive in a little bit more, I want to go over just the concept of NPI, because it's an important concept, and I don't think we utilize that enough. Probably because we're learning still a lot about it, and until recently, we didn't have all the right tools to make it as easy as possible for everyone to do. So we know that the myocardial performance index, also known as TI, after Dr. TI, who came up with the concept, is Doppler-derived index of the left or the right ventricle, right? And it's migrated from adults to pediatrics to fetal, right? Now, we also know, remember that concept I came up with, the modified MPI, where we are kind of cheating and using one gate to capture both valves? That's okay very early on, but if you think about it, most of these fetuses who get into trouble are in the third trimester, so that value, well, Dr. Chavez, what difference does it make if we use the left or the right and everything else? Well, remember that slide that actually said that we know that the right side of the fetal heart is doing the bulk of the work? That right side is actually going to show us sooner and more accurately when that fetus is getting into trouble or when it needs intervention, whether that intervention is an increased surveillance or delivery. The modification occurred because we were trying to make something easy, right? Because the calculations of looking at the timestamp on one waveform and then calculating the other one, it just was too complex. But when we do that to the left side, we realize that we might be capturing information, if at all, because sometimes the left side doesn't even get under that much stress, and it might not develop abnormalities that we could pick up. Unlike the right side, where the majority of the time you will pick up an abnormality and you will pick up a concern that will allow you to help that fetus or decide what best intervention to implement for the circumstance. A couple key points for MPI, right? We know that there is some points of interest when we look at these measurements, and when we look at the intravolumetric contraction time or the intravolumetric relaxation time, and I'll show you examples of those. those are key points where we actually measure the time stamps, okay? Where we know that those measurements need to occur for us to figure out if that fetus is in trouble or if that fetus is doing well under the circumstances that it's in. If we go to the next slide. Okay. So this is the left ventricular MPI. We know that we can capture it in both. We also know that if you look at, I'm going to put up some labels next on this. We look at the mitral flow, and you see the mitral flow, right? It looks like a range of mountains, or an M. Right? I remember that because my first initial is M. And then if you look at the next index, you'll see the mitral flow again. The interesting thing is because the valves are so close, you can actually not only get the mitral inflow, but you can also, if you look at that S portion of it, that's aortic outflow. And then you can measure the distance between when the mitral flow finishes and when the aortic outflow, as it's labeled there now, occurs. Now, the ejection time of that aortic outflow is going to allow us to come up with that index or that MPI for that fetus. Here's where it gets a little bit tricky. If we look at the right-sided, right, same concept, different valves. I'm going to put up some labels, right? You see that those valves, now it's on the right side, obviously. But what's a challenge is now if I trigger the next point on this slide, you'll see the ejection time, which is the same, but now it's for the pulmonary. But if I trigger that slide again, you see that that waveform is off because of the distance. So now I have to try to figure out how to measure those. Earlier on, it's a little easier if I do a modified NPI, which I can do, right, on the left side, not so much on the right side, or as accurate. But now I have to try to figure out, remember those two cameras? Well, one camera is up on top looking at the tricuspid inflow, one of those doors. And then on the bottom, you see the pulmonary outflow, the other door. So I can see what's going in and out, but I have to sync them in time to get accurate information. So we'll go to the next slide now. And we can see, because those valves are so close, and we can measure all of those, and these are very similar parameters that we use for all of these NPI acquisitions. We wanted to make sure that we have a large sample size. The angle should be less than 15 degrees, a very wide Doppler sweep, and also the Doppler gain and the motion filter, at least 300. I usually put it on. It says 200 to 400, but on the higher side, better. If we go to the next slide, you'll see the motion on this slide where we're actually able to see where we're able to capture the left ventricular NPI by just one gate. And by seeing that one gate, we're realizing that we can see both waveforms, right? We'll see the inflow, right? Since it's on the left side, it'll be the mitral, and we'll see the outflow. You can see that both waveforms are captured at the same time when it refers to the left side, right? But we're trading off easier with less information in the sense that it might not tell us if that fetus is truly in trouble, or it might tell us later on as opposed to earlier if that fetus is in trouble. So if we go to the next slide, you see a perfect example as to how that waveform is easily captured with that one gate. That one gate is able to capture, if I take the mouse pointer and I put it on the M, right, you'll see the mitral valve inflow. And then if you look at the downflow, right, you'll see that that's aortic flow. And then you can put your volumetric contraction time gates or lines, as well as your isometric relaxation time, and you can calculate your modified NPI, and that's the number that comes out there. If we go to the next slide, we realize that those isovolumetric relaxation time, isovolumetric contraction time is pretty straightforward to measure when both waveforms are in sync or in the same image. Now, where can I utilize this? Well, the options for utilizing this is becoming more and more, the list is becoming more and more. We're starting to utilize it in our institution for growth restriction, twin-to-twin, diabetes, fetal lung masses and tumors, diaphragmatic hernias, and hydrops. We realized that, yes, we can look for Doppler changes, but by the time some of these Doppler changes occur, one, they might be very late, and two, we might miss an opportunity to provide either steroids, increased surveillance, or timing of delivery for that fetus. And I'll share some studies that are coming out which actually have been sharing some new and exciting information as to how MPI, particularly right-sided MPI, might be the most useful tool that we can possibly have. But let's go over some key points before we continue. Right ventricle of the fetus shows right dominance, in which the right ventricle accounts for more than 50% of the total cardiac output. We know that, but we kind of cheat by looking on the left-hand side. Why? Because it's been too hard to try to figure out the right side until now. Now we have technology where we can compensate for this challenge or this difficulty. When cardiac dysfunction occurs, the right ventricle responds faster and more often. So even though it's easier to look at the left side, we might be looking at the wrong flag to give us that signal and saying, it's time, I need help. That fetus needs help. I need intervention. I need more monitoring. So we're looking at something that's easier to get, but might not give us the information we actually need to help that fetus, particularly in the third trimester. Okay, so we needed to decide how to bring this technology into our practice, because we knew it made sense physiologically as well as from when we reviewed the literature. We also knew that it had to be somewhat semi-automated because we didn't have the time, the resources to look at the images, calculate the images, compensate for the time difference, when it's desynced. We knew that it had to be something that we can have our team just capture on the right side the tricuspid inflow as well as the pulmonary outflow from those valves. So we started a program, which most institutions do, most high volume, where we wanted to train the trainer, the trainers trained the team, the trainer and learner teamed up to 40 scans. We reviewed images, right? A lot of quality controls, and then MPI Plus allowed us to pick up and store waveforms. The other thing is that even if they didn't perform the MPI Plus at that moment, the technology allowed us to go back to the stored waveforms and actually apply MPI Plus to those stored waveforms and get that information. We also wanted to make sure that we were putting this on the right location, the right valves and everything else. And we routinely do this. We are echo certified in our unit, but we wanted to make it user-friendly for as many people as possible in our team. And fortunately, the technology did allow us that luxury. Tricuspid valves and pulmonary valves we used to measure the right MPI, right? We knew that there had to be, those are the valves. We knew that that's what we were aiming for. If we go to the next slide. So this is one of the important papers that came out initially, and of course it came out in the International Society for Optics and Photonics. I don't know about you, but I'm not a subscriber to it, so we had to dig a little bit for it. But it actually came up and allowed us to demonstrate the concept behind it. So I'm going to go to the next slide, and you'll see that, one, we needed it to be simple. Two, we needed to be accurate and not slow down the flow of our fetal evaluations, because we wanted to make sure that we provided the best care in the fastest manner to our patients. We also knew that we wanted to keep it relatively straightforward, right? We know that AIUM recommends some basic views of the heart, and we wanted to make sure that those basic views included the views that we were going to need to capture the waveforms for our evaluation of the right ventricular NPI. And it included those. And as you can see from the highlighted ones, if we look at the bottom, we saw the right side of the heart, the flow from the ventricle to the atrium, as well as the pulmonary valve. If we go to the next slide, we'll see that our team needed to have this readily available. And we had invested in one of the technologies through Samsung, which is the Hera W10, and there was a package in there that allow us to automatically synchronize that right ventricular inflow and outflow so that all values like the left ventricular can be measured. Remember that sound check that I spoke to you about? It actually utilizes pulmonary valve closing clicks appear before the click of the tricuspid. So those are the two sound checks that the technology utilizes to allow us to synchronize those two flows from the tricuspid and the pulmonary. Next slide. This is from that original article I showed you from the International Society of Optics and Photonics. And what you can see, right, because the valves are apart and you put it just on the tricuspid and the top image, you only capture the inflow of that side of the heart. And you need to actually put the valve at the outflow, the pulmonary, to capture the other part, right? Now this waveform looks familiar. But remember that animation that we showed you about they're not synchronized and both those waveforms are sliding back and forth because they're out of sync? If we go to the next slide, we'll see that we needed to do this in a way that was going to allow our patient flow to continue at the rate we wanted and also capture the additional information without too much investment in time. We also wanted to make sure that we made it as user-friendly for everyone in the team, whether sonographers or the doctors. And we wanted to make it a little bit competitive because we want everyone to not only feel like they were learning a new skill set, but also a valuable skill set and something that we were encouraging everyone to learn. If we look at this video, you can actually see, this is a screenshot, and you can actually see us capturing the waveforms, right? So the top waveforms, you can actually see that M, which is going to be the tricuspid. And then I've already captured it, and then I can go and capture the pulmonary waveform and just select it and bring it on to that, right? And that allows me now to pick the waveforms or the rate of that waveform. And I want you to watch this very carefully, very important. Now, I've picked the waveforms that I like up on top and on the bottom. And then when I hit the next step, watch the markers on each of those waveforms. You see what happens? It automatically synchronizes them. But the technology also allows us to make sure that if we're not happy with that synchronization, if you look at the blue lines on the left and the yellow lines on the right, we're able to tweak that even further by precisely putting it on the waveform markers that we already know are established. So this way, that synchronization, which is so complex, as you saw, was just a button click away. So that synchronization of the tricuspid and that pulmonary automatically occurs through MPI+, and then we can get the information and the values that we need. Next slide. And what we did is we made sure that we did this over and over again, and we demonstrated that it could be easily done, and just like I had mentioned before, that the sonographer, even if that sonographer might have not necessarily been trained in MPI technology, they were able to capture those waveforms, which we routinely would anyway when we evaluate the heart. We're able to then go back and then pull up those waveforms and apply MPI+ in the console of that Hera W10. We also did it in different positions, in different gestational age, and we were able to reproduce it easily and accurately every single time. If we go to the next slide, we started implementing it first in IUGR patients, right? Because in our field, those are the fetuses that are most at risk. We always struggle as to the best timing for IUGR. There are guidelines out there from our societies and everything else, but I truly think that we can do better other than get steroids on board, follow some Dopplers and everything else. So this particular fetus had an abnormal right ventricular MPI, which we picked up using MPI plus. And interestingly enough, this fetus, when we put on the monitor, had decreased variability, and just a few days later ended up needing to be delivered. But we were able to get, because we were able to detect this, we were able to get steroids and that fetus or that pregnancy to deliver in the best possible location for that pregnancy. Next slide. We needed to keep it simple. We need to decrease time. We also need to help train and maintain these skill sets. And you know, one of the things, I have 3 sons, and one of the things that they're always teaching me is that, especially, you know, the younger generation, they're very eye-hand connected or eye-hand coordinated. And this technology speaks directly to what they're comfortable with. Having something visual, having something to activate, have something to target, and being able to get that information. Next slide. We have seen so far that the skill sets don't take more than half an hour or so, a little bit more than that. Once we overlap a couple of patients, less than half a dozen, team members have random quality control reviews of samples of the choir, and then we started to focus on these late IUGR, 3rd trimester. Next slide. We focused on these because these have the highest risk of morbidity and mortality for that fetus. In addition to that, we found that our office was being inundated with these increased surveillance, and we realized that we can actually space them out a little bit, and that's the goal that we're aiming for. And better management and timing of delivery, as opposed to saying, we got you to 34, we need to deliver you. Next slide. In our unit, and for the review of the literature, we decided to use a simple cutoff of 0.45 for the right ventricular MPI. That allowed us to have the best cutoff for our population to know when to deliver and where to deliver. And we're currently following these neonatal outcomes to see what, if we need to adjust that cutoff, and what the follow-up or what are the morbidities of these babies when they're born afterwards, particularly when it comes to cardiac function. Next slide. Other potential clinical uses of MPI in the future are as following. We're going to look at differences between left and right ventricular myocardial performance index, and we also see that there is already this correlation or a mismatch in that we know that the left side doesn't necessarily give us that signal where we're looking for. Next slide. We're also looking at management of heart failure in the fetus, right? Remember what I told you? What happens in utero usually affects us after birth and throughout our lives. So if we can intervene sooner and we can perhaps give better surveillance and better delivery timing of these fetuses, hopefully we can decrease the cardiac complications that these fetuses or these newborns might have later on in life. Because we know that these fetuses will have not only cardiac dysfunction, but later on higher risk of having other cardiac morbidity as they grow older. We also are seeing more and more literature supporting that NPI, particularly NPI on the right side, is going to be useful in these monitoring of these patients as well as the timing of delivery. Next slide. Interestingly enough, it's also being applied to other scenarios, which at first I was like, well, what does that have to do with cardiac function? But it makes perfect sense. Remember that fetal circulation? Well, if that placenta is in a location which is not ideal, well, that heart is going to not necessarily get what it needs and might struggle to get the vascular demands of that fetus. So NPI might actually be useful in these scenarios in figuring out if these fetuses are at risk not only for preterm delivery, because we know we want to deliver them earlier because of the concern about going into labor with the placenta previa, but actually they might even have later out concerns after birth, and maybe increased surveillance for those fetuses might be, or those newborns might be necessary. Next slide. We want to also figure out how to develop care that's going to change these outcomes. I just don't want to see it and say there's a problem. I want to see, okay, what else can we do to help these fetuses in utero? Next slide. We also know, right, in our center we do twin-to-twin transfusion, we do fetal procedures, fetal surgeries. We also know that there's a very vulnerable subset of patients, the mono-di twins, that their circulation is basically intertwined so closely through the placenta that monitoring with NPI, right-sided NPI, might be an additional next step or more careful way to evaluate the fetal health of these fetuses. Next slide. What we want to focus on in the future. Obviously, our unit, we want to continue expanding the number of late onset IAGR, expand to early onset IAGRs. We continue to expand on the vulnerable subset of pregnancies that includes mono-dis, twin-to-twin, TAPS, expand to pregnancies with uteroplacental insufficiency. And as you can see, that list is pretty extensive and grows on a regular basis. This is what is going to allow us to have tools to know how to best intervene and manage. And now we have a tool that is pretty straightforward, easily implemented, and easily reproduced when we need it for our patients. In summary, fetal heart evaluation continues to expand with faster and better technology. Fetal cardiac health is important for cardiac health for the rest of that individual's life. Very important concept to remember and keep in mind, particularly when we're pushing the envelope with this type of evaluation. These advances will only continue if the technology is simple, reproducible, and allow for the throughput of patients. NPI Plus meets these goals. NPI, with further advance our abilities to monitor and manage these fetuses at risk. And with that, I'd like to finish. And if anyone has any questions, I'll gladly take them. Thank you very much.